Okay, this is a repurposed slide deck, but it's an update for the 2026 Dyslipidemia Guidelines. So we're going to do this real quickly. But essentially, it's just, going from risk to reaching and how the 2026 guidelines get us there. We'll assess patient risk, refine it, and then implement therapies. So here we go. Okay, so what you'll notice is that over time, some of you have been around long enough that we've moved from ATP1 and this treatment target of 130. Of course, this is in an era of the 4S trial where they enrolled LDL cholesterols of 190 milligrams per deciliter. Arguably, it was an FH population. And so over time, you can see that this goal has dropped and dropped and dropped and dropped. And for some reason here, the ESC kind of had that 40, kind of went away a little bit, but came back again on this side of the fence, where now ACC and AHA are saying, yes, let's go to less than 55. Often tell my patients Europeans have leapfrogged us, and at a little moment in time, the clinical endocrinologists in America also did, but then they backed off. Who knows? So here are the updates. Really, it's kind of this continuation of very high risk ASCVD. We'll define that, but the LDL cholesterol goals are back, less than 55 milligrams per deciliter. ASCVD, not at very high risk. Essentially, these are people who have had an event. It's been a while. LDL cholesterol less than 70, high risk primary prevention, LDL less than 70, borderline intermediate. You can probably relax to less than 100. I don't think so, but the guidelines say so. And yay, coronary calcium at the highest level of 1,000 or greater, less than 55 milligrams per deciliter, making sure that we know these are high-risk individuals. So these are the 6 groups that warrant LDL cholesterol lowering therapy. Before we had, 4, sorry, I did 3. 4 groups. Now it's 6 because subclinical atherosclerosis gets added to the mix, and then hypertriglyceridemia comes back into the fold of dyslipidemia guidelines. But for everyone here, the main thing is to remember percentage reduction, 50%, and specific threshold goals of less than 100, less than 70, less than 55. So let's go at it. Lifestyle modifications, of course, it's not very successful in saying, these are the things you do to lower cholesterol. No, I tell patients, these are the things you do to improve quality of life, to make sure that you have health in the longevity that we hope we have. But these certainly can reduce LDL cholesterol, mainly through different mechanisms for which, we ingest, we do all sorts of metabolizing, etc. But nonetheless, I tell people lifestyle is important, but don't rely on it for LDL cholesterol lowering. Okay, here we go. So when we think of the therapies around the world of liver, then we recognize statins are here with HMG-CoA reductase inhibitor, and bempedoic acid, or Nexletol Nexlizet, it's not a CME certified talk, is up above that in this citrate lyase inhibitor. So it's just upstream from statins, but it does not have any mechanisms within muscles other than uric acid can go up and gout can be a problem. Here, we're looking at the villi in the intestinal region, but NPC1L1 also exists as a receptor on the liver, not just in the gut, and I call it the bouncer. Stops cholesterol from coming in to the system, whatever we're eating, but also kicks people out once they're out in the gut. We don't recycle it very well when ezetimibe is there. And then on this side of the fence, this group has been exposed to the term inclisiran and small interfering RNA, and then PCSK9 inhibitors such as evolocumab, alirocumab, better known as Repatha and Praluent. Okay, this is how we use the 2026 guidelines. We start with CPR, calculate risk. And I know Brent is going to be like, but Viet, tell me about the prevent risk score. Actually, I have a whole open evidence document I'm going to send right to you, Brent, so that you can see the differences and how the validation occurred. So calculating risk. This is using the ASCVD risk score. There's two others. There's the CVD and the heart failure. This is a specific 10-year risk score for ASCVD. And they've expanded the ages on both horizons. So instead of 40 to 75, it's now 30, recognizing that's a better time frame to start primordial care. And then 79, recognizing, hey, we have folks that are very, very healthy into our later decades. Okay, but you shouldn't use this if you have FH, familial hypercholesterolemia, or if ASCVD already exists. Then there's a 30-year risk as well. Once we've done that, we personalize risk, and then we go to reclassifying risk with a coronary calcium. So you'll see it's been pulled out of risk enhancers because it's its own thing. But this is the most important thing to think about, is these percentages. So previously we were familiar with 5 to 7.5, 7.5 to 19.9%, and then 20. But now low risk is less than 3%, and then borderline is 3% to less than 5%. Now the folks that we tend to think of as this is consider, there you go, lower lipid lowering therapy, and then of course recommending or should be considered in the intermediate and the high risk groups. Here is the risk enhancer table, and you'll find that of course the usuals are here. Family history, higher risk ancestry has been added in with South Asian, Filipino. Polygenic risk scores make it back in here. Chronic inflammatory diseases, CKM is new. That is something that's been added on there. Of course, reproductive risk markers, early menopause, preeclampsia, gestational diabetes, HSCRP, please do. Order this. It's helpful, and then it's on greater than one measurement, and not when they're sick. Okay, it's an acute phase reactant. So elevated triglycerides, persistently elevated LDL, and we'll talk more about Lp(a) later. This is a nice cheat sheet here. Star. Okay, so borderline to intermediate risk, high risk folks, very high risk. And now it's including individuals all across the 6 groups other than triglycerides, but where their LDL cholesterol goals are, including non-HDL and then optional ApoB. I know I'm in the way, I'm sorry. But in essence, what you'll know is that it's fairly similar from LDL to ApoB now, instead of like this 10 milligram per deciliter shift, other than right here, it's pretty similar. Okay, so using ApoB to assess residual lipid-related risk, I think we're going to find a time that ApoB is the marker, not LDL cholesterol. But in any case, when should you consider ApoB if you're not doing it all the time like I am? Then CKM, which is greater than 90% of the population, has some staging of CKM, and then diabetes, triglycerides greater than 200. So if LDL cholesterol is kind of at goal, but ApoB is not, then certainly this is a chance for us to intensify therapies. Back to the 6 groups. So clinical ASCVD, primary prevention, severe hypercholesterolemia, FH, subclinical atherosclerosis, diabetes, and hypertriglyceridemia. So let's look at primary prevention. Here we are calculating the 10-year risk score, and then we look at risk enhancers. I do this regardless if they're low risk, borderline, intermediate, or high. But here the call outs are that there's actual percent risk strata based on how high your Lp(a) is, and then new CKM is in here. New also, CAC gets pulled out of risk enhancers and is part of the subclinical atherosclerosis. Here you go. So we know this. I'm not going to belabor this slide, but this is a cool slide. I love it because it goes from CAC 0. You can defer in certain groups, not in diabetics. Kirk, I see you. FH, tobacco use, and then family history of premature ASCVD. And those, the LDL cholesterol greater than or equal to 190. So when, repeat 3 to 7 years. And I would do the Kaplan-Meier so that you can see it, but I draw it for my patients so they understand why that time frame helps. In that 1 to 99, you have an optional goal of less than 100, 100 to 299, goal, green, class 1, less than 70, 300 to 99, then it's again less than 70, but optional less than 55. Just shoot for it. Come on, you're almost there. And then 1,000 or greater, less than 55. Okay, so cheat sheet again. I'm not going to belabor this. These are the 6 groups. These are HDL less than 100, less than 70, less than 55, and then what the context is. So another ding, 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 cheat sheet one. Putting it all together, I'm not going to walk you through this other than to say we calculate that total risk, we do personalization, and look at reclassification with subclinical atherosclerosis. And then you march on down whether or not they just need lifestyle itself or therapeutic objectives. And then you're adding in, of course, maximally tolerated statins, and all the non-statins start getting added in here, okay? Lp(a). You've heard this many, many times from our venerable, distinguished clinical researcher, Dr. Anderson. So I'm not going to belabor this point other than Lp(a) is important because it's the same ApoB 100 molecule as LDL cholesterol, but happens to have a bond here and carries lipoprotein little a. And the kringles make a difference. We just don't assess for that at this point. What does it lead to? Well, low Lp(a). This is more of a slide in terms of aortic stenosis and where the atherosclerosis can occur. Left off of this is thrombogenesis, but this is, the problem with Lp(a) or potential problem. And then here, of course, coming back to the risk enhancers, but I like the next slide better because at different nanomoles per liter, and as you increase the number of the molar content of Lp(a), then your risk increases also with that. Okay, so it's important, and it tracks also with milligrams per deciliter. I'm just not adding it on here, but it's important to recognize that. Here are the Lp(a) lowering therapies that I will call it drug. I should have titled it as Lp(a) lowering drugs. We don't know if they're therapies to this point because that's what a cardiovascular outcome trial is about. And I'll just say here that we are part of Pelican and we are part of Love, and then very soon here, Muvalaplin. So yay, we'll see if this works. Okay, so why do the Lp(a)? Why is it universal, by the way? Okay, second guideline, NLA statement, and now 2026 says universal because 20% of the population were missing that they have this elevated risk. We can maximize statins and consider aspirin with a risk-benefit discussion. Consider PCSK9. It's class 1. So if someone needs further LDL cholesterol lowering and they have